Today, we will delve into perioral dermatitis and its variant, periocular dermatitis, collectively known as perioral dermatitis. Despite its name, this condition is not a true dermatitis, a misnomer that can mislead clinicians. Our discussion will cover its etiology, clinical findings, and management strategies. Introduction: Perioral dermatitis is an erythematous eruption characterized by small papules and papulopustules, primarily distributed around the mouth. In some cases, it involves the skin around the eyes, presenting as periocular dermatitis. Its misleading name often obscures its true nature. This is not a dermatitis in the conventional sense. Etiology: the precise cause of perioral dermatitis remains unclear, but certain triggers are strongly implicated. Topical steroid therapy, a key factor, either through direct application or indirect contact, e.g., transfer from fingers applying steroids elsewhere. Cosmetics, moisturizers, and sunscreens, these may also provoke or exacerbate the rash. Understanding these triggers is essential for effective management and patient education. History: perioral dermatitis predominates in younger women, often presenting with symptoms that can range from itching to soreness. Its impact on quality of life, though subtle at times, should not be underestimated, particularly when symptoms persist or recur. Clinical findings: distribution: nasolabial erythema is often the first sign. The rash predominantly affects the perioral skin, sparing the lip margins, a hallmark feature of perioral dermatitis. Periocular involvement: periocular dermatitis is less common but should be recognized as part of the spectrum. Morphology: the eruption consists of monomorphic small papules and pustules, accompanied by erythema, occasional scaling. Importantly, unlike rosacea, facial flushing in telangiectasia are not features of perioral dermatitis. This distinction aids in accurate diagnosis. Management: effective management of perioral dermatitis involves a combination of prevention, education, and targeted treatment. 1. Prevention and steroid discontinuation: avoid transferring topical steroids to the face. If steroids are used on distant sites, e.g., for eczema, ensure hands are washed thoroughly after application. Discontinue any topical steroids applied to the face, as well as other facial creams that might be contributing to the condition. Patients should be warned about a temporary flare of symptoms following steroid withdrawal. This can be mitigated by tapering the steroid use over 1 to 2 weeks before complete cessation. Treatment: milder cases, topical antibiotics, clindamycin or erythromycin are effective first-line treatments. Moderate to severe cases, systemic antibiotics, tetracyclines, limacycline, 408 mg OD, or doxycycline, 100 mg OD, for 6 weeks. For patients with contraindications to tetracyclines, clarithromycin or erythromycin can be prescribed for the same duration. Recurrent symptoms: recurrent cases are managed similarly, with adjustments based on patient response and tolerability. Conclusion: perioral and periocular dermatitis, though not true dermatitis, represent a common yet often misunderstood condition. Its management requires a careful balance of identifying triggers, educating patients, and employing evidence-based treatments. By understanding its etiology, clinical presentation, and therapeutic options, we can provide patients with effective relief and prevent recurrence. Thank you for your attention. I welcome any questions or discussions on this topic.